Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, "The Assessment of Tumor Size Reduction Improves Outcome Prediction of PET-CT After Chemotherapy in Advanced Stage Hodgkin Lymphoma" by Karsten Kube et al. My name is Bruce Chesson, and I am Deputy Chief of Hematology Oncology and Head of Hematology at Georgetown University Hospital and the Lombardi Comprehensive Cancer Center in Washington, D.C., USA. My hematologic oncologic specialties include development of new therapies for lymphoid malignancies and assessment of response. Hodgkin lymphoma is clearly one of the great successes of modern hematology oncology. More than 80% of patients with advanced stage disease are cured using standard chemotherapy regimens such as ABVD or the intensive BIACOP program, which is used primarily in Germany. However, how best to distinguish those patients who will fare well from those who will relapse and potentially succumb to their disease has been a challenge. Recent data using PET-CT scanning demonstrate that this technology has an important role in response assessment. Indeed, in the 2007 IWG response criteria, PET-CT was adopted as the standard method of assessment for FDG-avid histologies such as Hodgkin lymphoma. Now, it has been incorporated as the standard for staging of FDG-avid lymphomas in the recently revised staging criteria. Numerous studies have shown that the negative predicted value of PET-CT is greater than 90%. Therefore, fewer than 10% of patients with a negative end-of-treatment scan will relapse. The manuscript by Kube et al. From the German Hodgkin Study Group provides data that the CT scan may provide complementary information on how best to identify and potentially manage that other 10%. The authors from the German Hodgkin Study Group conducted a retrospective analysis from their HD15 trial. The treatment portion of the study has been previously reported. They accrued 2,182 patients with newly diagnosed advanced stage Hodgkin lymphoma to a study that involved a comparison of various BIACOP-based induction strategies. 8 cycles of escalated BIACOP versus 6 cycles of escalated BIACOP versus 8 cycles of BIACOP administered every 14 days. However, HD15 also addressed an important imaging question: how best to approach patients with a residual mass following chemotherapy. The availability of PET scans has made it possible to distinguish viable tumor from scar or fibrotic tissue. Following treatment in the HD15 trial, patients without any residual disease by CT were followed without additional treatment. Those with a mass of at least 2.5 centimeters on CT underwent a PET scan. If the PET scan was negative, they were followed with observation alone, while those with a positive scan underwent radiation therapy. More than 85% of patients who were PET positive remained disease-free, a figure that was significantly lower than the PET negative group for whom it was 91.5%. Importantly, incorporation of a PET scan into the decision-making process had reduced the number of patients subjected to radiation from 70% in earlier studies within that group to only 11%, with no decrement in overall survival. Thus, as a result, almost 90% of patients were spared unnecessary radiation therapy. In the present manuscript, the authors conducted a retrospective analysis, including a subset of 739 patients from the original 2,182, of which 191 had a scan that was still positive by visual analysis following treatment. Of these, 52% had presented with a large mediastinal mass with a median diameter of 9 centimeters. A greater than 50% shrinkage was observed in these patients with Biocop-based chemotherapy. The authors found that CT could distinguish PET-positive patients into low and high-risk groups with a cutoff of 40% tumor shrinkage. In the overall group, the rate of relapse over the first year was 10.7%. However, selecting those patients who also experienced a greater than 40% decrease in largest tumor diameter, it was only 5.3%, compared with 23.1% with a lesser reduction. This difference translated into a long-term advantage with a 4-year progression-free survival of 40% versus 72.8%. Importantly, in the low-risk group, there were no events after the first year, suggesting they were cured by the additional radiation. A critical observation was that most of the relapses occurred within the radiation field, supporting that we need to focus on more effective initial approaches rather than waiting to attempt to salvage patients, which has been less successful with Biocop regimens than the more widely used ABVD. To put these important findings into context, in 2012, investigators from the then CALGB, now Alliance, first published similar observations, not referenced in the current paper, on patients with limited-stage Hodgkin lymphoma, in which the combination of a positive interim PET scan and a suboptimal decrease in the sum of the products of the diameter of the tumor size predicted for a worse outcome than the other permutations. Casasnovas et al. From the Gila group have also come to similar conclusions in patients with diffuse large B-cell lymphoma with the combination of PET and the percent decrease in the SUV as a better predictor of outcome than PET alone. In conclusion, whereas PET has made important contributions to both staging and response assessment, further refinement in how we assess patients with this technology would be valuable. Whether it is the combination of a decrease in tumor size or the amount of reduction in SUV remains to be determined. Defining the best combination of factors will clearly maximize our ability to treat our patients with Hodgkin lymphoma with a risk-adapted approach, minimizing toxicity in favorable patients while improving outcome for the unfavorable ones. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.